everybody, and welcome to another video. Today we will be talking about nephritic syndrome, also known as glomerulonephritis. This is kind of a sister lecture or brother lecture or partner lecture to the discussion we did on nephrotic syndrome the other day. The setup will be similar to that. Before we get into it though, a quick channel plug. This is the channel of the Whiteboard Doctor. We are a medical education open access YouTube channel trying to bring you relevant and important content. We have a subscribe button in this bottom right corner. If you feel inclined and you want to follow along, please feel free to press that. We appreciate you. In addition to that, a few channel plugs. We have a Patreon page. Feel free to go to the description of this video and check out that page. We'd love for you to become a patron, get some merchandise, behind the scenes look. We are also part of the YouTube membership, so you can go to our homepage and click join to become a YouTube member. In addition to that, we are part of a website called Buy Me a Cup of Coffee. It's for creators, where people can go and kind of give them a quote-unquote tip to buy them a quote-unquote cup of coffee if you enjoy what you saw and you have the financial means to do so. We appreciate you all. Nephritic syndrome, glomerulonephritis, what is it? So if you saw our nephrotic syndrome lecture, which we will link in the description of this video, you will know that the way we like to talk about these is by actually starting with the clinical findings and then transitioning into how those clinical findings relate to the pathophysiology. We'll then use that pathophysiology to explain the workup, what you'll expect to find. After that, we'll talk about the kind of major diagnoses and then what we need to do to manage those diagnoses. So starting with clinical findings. In nephrotic syndrome, nephritic syndrome, the clinical findings are several-fold. So you will see proteinuria. Now, if you saw our nephrotic syndrome lecture, you'll say, hey, wait a second, proteinuria was significant in nephrotic syndrome, not nephritic syndrome. Just know that this is kind of a spectrum disease with nephrotic syndrome. You can actually have nephrotic range proteinuria with nephritic syndrome, but typically in nephritic syndrome, your proteinuria is less than 3.5 grams per day. And if you remember in the nephrotic syndrome lecture, that had greater than 3.5 grams per day. In addition to that, we're going to get hematuria or red blood cells in the urine. Third, we're going to get pyuria or white blood cells in the urine. 4, we're going to get hypertension or high blood pressure. 5, edema or soft tissue swelling. 6, we're going to get anemia or low blood cell counts. And then 7, we're going to get Azotemia, which is elevated BUN and creatinine. So why in the world do we get these clinical findings with nephritic syndrome? To do that, we're going to draw some things, me and my fantastic artwork. So the first thing we're going to draw is this fun bean-shaped organ, strike one, this fun bean-shaped organ, right, called the kidney. And the kidney, if we zoom in on a clump of it, is built up of nephrons. And nephrons are fed by an afferent and efferent arteriole, and those feed the glomerulus. So this is a, strike two, fat glomerulus that I'm going to make more shapely. So this here is going to be the afferent, and blood flows into the afferent and then goes into the glomerulus. In this glomerulus, you have a bunch of blood vessels, capillaries, all twisted together. Things, that's a great descriptive word. Different liquids and molecules will leak out of the glomerulus into Bowman's capsule, and we'll get into what that is. And then those that remain within the capillaries will then be transported out of the efferent arteriole and then out of the venous system of the kidney. All right, so Bowman's capsule leads to our nephron, right? And our nephron, we have a proximal convoluted tubule that goes into the thick and thin descending into a distal convoluted tubule and then a collecting duct. So if you can just, picture it, it looks kind of like this. All right. And when we're talking about glomerulonephritis, what we need to understand is how the glomerulus is affected. So just like we zoomed in on a hunk of kidney, we're going to zoom in on a hunk of glomerulus. And what we'll see here is an individual capillary. The individual capillary, right, will look like this, and it's coated by endothelial cells, which make up the blood vessel wall, right? And if you saw our previous lecture on nephrotic syndrome, you might be familiar with the capillary in the glomerulus being surrounded by podocytes. These are finger-like projections that assist in making a tight barrier so that not many things except the things you want can leak out of the capillary into the nephron and thus be secreted in the urine. In nephrotic syndrome, it was the podocytes that sustained an injury. In nephritic syndrome, though, it's actually the capillaries. So what happens? Within a capillary, we have a whole bunch of stuff, right? We have proteins, we have red blood cells, right? We have antibodies, antigens, complement, all that. In nephritic syndrome, what we get is actually an immune reaction against the endothelial cells that line this capillary. So unlike the podocyte injury, the injury here is primarily in the endothelial cells, and you get an immune response. So you'll get antibodies, your antibodies that start to attack the endothelial cells. Because of that, you'll get complement activation, and you'll start to recruit immune cells that will then also start to attack those endothelial cells. So what happens then? Well, as you can imagine, you're going to sustain an injury to those endothelial cells. And those nice tight junctions start to widen, right? So instead of the nice tight junctions that you had where the endothelials touch one another, you start to get a widening, and you still have podocytes, but with endothelial damage, your podocytes aren't as tight either, and you start to get things that are going to leak from inside this vessel to outside this vessel into Bowman's capsule and the nephron. What are those things? Well, since your endothelial wall has been injured, a big one is red blood cells. So you start to get the leakage of huge numbers of red blood cells that leak out into the nephron. In addition to that, you recruited all these white blood cells because of the immune response. So you're going to get white blood cells that also leak out of the capillary into Bowman's capsule. Just like with nephrotic syndrome, you will also get protein that is leaking out of the glomerulus intravascular space to the extravascular space in Bowman's capsule. So what does this look like then, right? We took a hunk out of the glomerulus, and we're saying now that we're going to get these big numbers of increased red blood cells, these increased white blood cells, and then increased protein that are all secreted out of the glomerulus into the nephron. And then just like things do, they're going to travel through the nephron, and they can't get reabsorbed because the rest of the nephron has these tight junctions. They're going to be secreted into the urine. And we're going to get into testing and what these then will show us when they're in the urine. Okay, so why then, again, do we get these clinical findings? Well, we see here that you're going to get proteinuria, right? Because you're going to be secreting your protein out through the nephron into the urine. So that's number one, proteinuria. Now your podocytes aren't as damaged, and the proteinuria doesn't typically be as high as it is in nephrotic syndrome, but it is a range. Then they also, clinical finding of hematuria. Well, we damaged our endothelial cells with this immune reaction, right? So we're going to get red blood cells that leak from the glomerulus into Bowman's capsule, and they're secreted into the urine. So we're going to get hematuria as a clinical finding as well. And this is number 2, right? All right, what's number 3? Number 3 is pyuria. Well, since we had that immune response to the antibodies and complement attacking our own endothelial cells, some of those white blood cells are also going to leak out of the capillary into Bowman's capsule and be excreted into the urine. So we're going to get pyuria, which is increased white blood cells in the urine. And that is going to be number 3. All right, what's number 4? Number 4 is hypertension. This is when things can get a little more complex. To understand this, I'm going to tie in azotemia in number 7. So as we mentioned, we have this injury to the glomerulus, and we have all these things leaking out of the glomerulus into the nephron and being excreted in the urine. Well, these afferent and efferent arterioles that are feeding the glomerulus detect this, and they detect it through the activation of, let me get a smaller caliber marker here, the Renin-Angiotensin Aldosterone system. And the Renin-Angiotensin Aldosterone system says, hey, we're losing all this fluid in the urine. We need to intervene to increase our intravascular volume. So what they do then is they start to absorb more sodium, which then absorbs more water. And by absorbing more sodium and more water, we're going to get increase in the intravascular volume, right? Because all that fluid and salt is staying in the blood vessels. And as a result of that, we're going to get higher blood pressures or hypertension, right? And that is number 4, hypertension. Related to this is azotemia. So why did I relate azotemia to this? When the kidney is injured and RAS system is activated, what we can start to see is an increase, let me get a smaller marker, is an increase in our creatinine, an increase in our BUN or urea, and a decrease in our GFR or our glomerular filtration rate. And these are, the diagnostic criteria for azotemia, and specifically for acute kidney injury. So in glomerulonephritis, you can get azotemia and acute kidney injury. Secondary to this glomerular injury and the blood flow deficits that occur in the afferent or efferent arterioles because of it. All right, that leaves us with edema and anemia. So for edema, if you watch our Nephrotic Syndrome lecture, you'll understand this a little bit. We're losing a bunch of protein in our urine. If we think about what leads to kind of intravascular volume, this is going to be a vein. And we have kind of the extravascular space here, right? The interstitial tissues. And then we have the intravascular space inside the blood vessel. And there's 2 main forces affecting how much fluid stays in the blood vessel versus how much fluid goes outside the blood vessel. And that's going to be hydrostatic pressure, which is the physical pressure gradient caused by the fluid in and outside the vessel. And in nephritic syndrome, like nephrotic syndrome, that hydrostatic pressure is increased, right? Because as we talked about, the renin-angiotensin aldosterone system stimulates retention of sodium and water. So we're going to have an increased hydrostatic pressure manifested by increased sodium and increased water from the renin-angiotensin aldosterone system. That'll then lead to fluid leaking out from increased hydrostatic pressure. In addition to that, as we've talked about, there's a bunch of protein. Protein is being lost in the urine, right? Proteinuria. This affects another force called oncotic pressure. Oncotic pressure is the gradient between the intravascular kind of osms and proteins and the extravascular. And it's not osms because those can travel freely, but it's things that don't travel freely, things like proteins. And this is the oncotic pressure. And when we lose a bunch of proteins, right, because we're getting a bunch of proteins being lost in the urine, so it's no longer in the vascular space, this oncotic pressure starts to favor water flowing out of the vascular space into the extravascular space, because water follows the highest density of these proteins. So water, as our proteins intravascularly become depleted, will start to leak out of the vessel to follow that gradient towards the extravascular proteins. And thus we see fluid leaking out of the intravascular space into the extravascular space, causing edema and swelling. All right, and this was, what number was this? Edema is number 5. So this is number 5, or edema. And then last we have number 6, anemia. This is a somewhat simple one because it's directly related to the blood in the urine. Sometimes you can have so much hematuria that we have a decrease in our hemoglobin peripherally, which is obviously termed anemia. All right, so then this is number 6. So if we zoom out now and we look at kind of everything we've put together here, what we see is that for nephritic syndrome, we get these clinical findings. Proteinuria, because we have an injury to the endothelial cells in the glomerulus leading to protein leaking out into the urine and being urinated out. Hematuria, because this endothelial injury from the immune reaction against the endothelial cells allows red blood cells to leak out into the urine as well. This can then lead to anemia if enough red blood cells leak out into the urine. Pyuria, because the initial injury in glomerulonephritis or nephritic syndrome is an immune response against these endothelial cells in the glomerulus. White blood cells are then stimulated and attracted to come, and those then can also leak out into the urine, leading to white blood cells in the urine, or pyuria. Hypertension, because as this glomerular injury progresses, the afferent arterioles get modulated by the Renin-Angiotensin Aldosterone system. This leads to the retention of sodium and water, which increases the intravascular volume and can lead to hypertension. Related to this is edema. As our hydrostatic pressure increases in the intravascular space and our oncotic pressure decreases through the excretion of all these proteins in the urine, so we have less in the intravascular space, fluid will leak from intravascular to extravascular spaces as that oncotic pressure, and I didn't draw this, as that oncotic pressure is decreased and that hydrostatic pressure is increased. And then azotemia. We have glomerulonephritis, we have injury to our glomerulus, and thus we start to sustain a kidney injury. This leads to an increased creatinine, increased BUN, also known as azotemia, and an acute kidney injury. All right. So now that we have all this information, what is going to be our workup? Right? What do we want to order and why? So the first thing, as with many renal conditions, is a urinalysis. The urinalysis is going to give us a microscopic review of if there's red blood cells, white blood cells, and protein. You would expect all 3 of these in the urine if it's glomerulonephritis and nephritic syndrome. You're also going to want a urine sediment. A urine sediment, you look at the urine under the microscope and look for casts. Casts happen when things clump in the nephron and they're urinated out as a clump. It's microscopic, you don't see it with the gross eye, but you're going to expect to see red blood cell casts, right? Because all these red blood cells producing hematuria are going to clump together and you're going to urinate them out. All right. In addition to that, you're going to want a basic metabolic panel to look at the kidney function, as well as the potassium. You'll want a magnesium and a phosphorus because you can get electrolyte derangements with an acute kidney injury. And this is to look for the azotemia and the acute kidney injury and any resultant electrolyte abnormalities. In addition to that, you're going to want a few different things to work up the cause: a complement 3 and a complement 4, anti-streptolysin O, double-stranded DNA, hepatitis B and C, ANCAs, and then eventually you're most likely going to also need a renal biopsy to confirm the diagnosis. So why do you need these lab studies? This is to diagnose the glomerulonephritis. These are to try to figure out the cause of the glomerulonephritis. So we're not going to dive in deep on the different causes of glomerulonephritis and how to manage them, but I will just mention a number of them. So glomerulonephritis is typically secondary to a few major causes. Remember, this is an autoimmune reaction against the glomerulus. You get your own antibodies that attack it because that complement is activated, and you destroy some of these endothelial cells. So the C3 and C4 is expected to be decreased because you're using it up as your immune system attacks the endothelial cells. In addition to that, you're going to have possible etiologies such as vasculitis. So ANCA vasculitis, which is why you want the ANCA level. You can get complex mediated, as well as, just general immune mediated glomerulonephritis. I'm just going to abbreviate GM. You can get membranoproliferative glomerulonephritis, which is another subset of autoimmune. You can get anti-basement membrane glomerulonephritis. Oh, this should be an N, by the way. Also known as Goodpasture's disease. You can also get rapidly progressive glomerulonephritis. Now, some of this can be virally induced, including Hep B, Hep C, and then antistreptolysin O, which is for strep throat. Some of these can be autoimmune induced. There's a kind of a whole spectrum. So I'm not going to go into these individual ones in this video. I think each one of those will get its own video, but I just wanted to kind of put the different possible basal causes of the glomerulonephritis on your in your mind, because it relates to the workup that we would do. Sorry, let me mute my computer. All right, so that is nephritic syndrome or glomerulonephritis, as explained through the clinical findings and how that relates to the pathophysiology. I hope that understanding it that way is helpful. Let us know what you think. Comments, questions, concerns. Feel free to hit that subscribe button in the bottom right corner if you feel inclined. Hope you all stay well, and we will see you all next time.